So oxygen, you kind of just need to know everything about it. Does anyone want to describe it for me?
Oxygen's an element, and it's a clear, colourless, odorless gas.
Good, very good.
Lipid soluble and weighs 32, molecular weight of 32.
Okay, good. All right. How's it made?
Fractional distillation. Yeah.
Anything else?
Can be concentrated as well against a zeolite mesh.
Yep. Okay. Anything else?
I suppose you can manufacture it by chemical reactions of some sort.
Yeah, you can. The other one that it's sort of my sort of like little throwaway was electrolysis of water as well. So fractional distillation, using an artificial concentrator of a zeolite mesh, and then electrolysis of water. And I won't ask you about fractional distillation until fibers come up. Okay, stored, used, carried effects. This is all stuff you have to know. So my kind of description. So I used to say, yeah. So essentially, it is an element, but we talk about molecular oxygen, which is O2 with a molecular weight of 32. It is a clear, colourless, odourless, tasteless gas, which is non-flammable but supports combustion and is required for the majority of eukaryotic and a significant amount of prokaryotic life on Earth. And that's kind of like oxygen, right? Like it's important. Then when you talk about how it's made, knock out those 3 points. How's it stored? Well, it can be stored as a gas or in a liquid, and we know what those are. So in a VIE, it's stored in both gaseous and liquid phases. And then in our canisters, it's stored as a gas, all right? And you should be able to sort of talk about the description of those, what they look like, what the pressures are, what the temperatures are, critical pressure, critical temperature, all that sort of stuff, okay? Usages, good. Carried, all right. So another good question is, how is it carried in the body?
So in 2 fractions, it's bound to hemoglobin and then it's dissolved as well.
Good. All right. And what's the percentage?
So the percentage bound to hemoglobin is really large, and I've got word finding difficulty for an amount at the moment. And the dissolved component is 20 grams. So is it like 1% and 99%? Is that right?
Yeah, it really depends on the textbook, but normally sort of a safe bet would be 98.5% bound to hemoglobin and 1.5% dissolved portion.
Yeah.
Okay, because remember, unlike CO2, it's got a solubility coefficient of 0.003 mils per deciliter per milliliter of mercury. So its Henry solubility coefficient is lower than CO2, therefore you won't get a large dissolved portion. And then other questions which throw people sometimes is, how is it stored in the body? Does anyone want to have a go at that?
2 ways I've already alluded to, and then I think we can also talk about it being stored in the FRC, so other areas that it's stored in, so FRC, and then I suppose if you weren't breathing, if you're breath holding, it could be stored in your pharynx as well, so your upper airways as well as your FRC.
Yeah, good. So we've talked about blood, functional residual capacity. Where else? So
myoglobin, other types of globins.
Yeah, good. Yeah, good. So myoglobin, and then obviously in the cellular the cytosolic component of the cells as well. Yeah. So they're sort of the five main areas that it's stored, and there's a percentage and a volume depending on whether you have an FI of 0.21 or 1. And there's actually a page in Brandis which has all those values for you. Cool. All right, effects. So I won't go into a full physiology viva here and talk about how oxygen, results in cellular metabolism. But what I will touch on is toxicity, because I don't think it's covered really well in a lot of textbooks, but there's a great BJA article on it. So I'll just quickly talk to you about it. So when you talk about toxicity, a good classification for it is normobaric hyperoxia and then hyperbaric hyperoxia, right? So normobaric hyperoxia, this is where you have sort of an FI of greater than 0.6 for 24 hours. That's sort of one of the quoted toxic levels. And hyperbaric is obviously greater than one atmosphere often we talk about convulsions and seizures at 2 atmospheres. And then you need to talk about the other types of toxicity. So the fact that it can be a vasoconstrictor post an MI, so you might actually want a lower FI in a patient like that for concern about causing sort of a Prinzmental angina episode in someone who already has a demand supply issue. And then the other things would be your neonates, all right? So your retrolental fibrodysplasia, your necrotizing enterocolitis, those sorts of things. And then reactive oxygen species. So if you just Google oxygen toxicity BJA, there's a fantastic article that explains it all, but you essentially can talk about the different types of reactive oxygen species. And the main ones are your superoxide anion, the hydroxyl radical, and that's created by, I believe it's the Fenton-Hubbard-Wise reaction. So these are just some points that you can sort of actually, like when you talk about oxygen toxicity, you can actually say, oh, well, this is what it is, and this is when it occurs based on an FI and a time frame. And I'll find the BJA article for you, and I'll send it to Stan. You can send it out. But it's a really good one. It's only like 2 pages, 2.5 pages. And then measurement. So I will ask you this question. So how can oxygen be measured, and how would you classify this if it was a viva?
So you
Not sure.
I was going to say, you could say invasive and non-invasive ways.
Yep.
Or you could say ones that are in the anaesthetic machine, ones that are not in the anaesthetic machine, or ones that are breath by breath or not breath by breath.
Yeah, I think they're all very reasonable. I'm just going to crack on with my mnemonics and see if you like them.
Okay.
So my sort of classification, the way I went about this was it can be measured. So these are the classifications. So tension, saturations, concentration, and then content. All right. So they're sort of the main ways you can measure it. From a tension perspective, I just say keep it PG. So the PG is, so P is polygraphic or Clark electrode, and G is the galvanic or the fuel cell. Then from a saturations perspective, you have co-oximetry, where you actually get fractional saturations, and then pulse oximetry, which we all know well, where you get functional saturations. And it's important to know the difference between functional and fractional saturation as well. And then from a concentration perspective, I just sort of, my mnemonic was resting membrane potential, or RMP. So Raman's spectrography, mass spectrometry, and then paramagnetic analysis. RMP, yeah. And then content is direct and indirect, and that's where you have your Lloyd Haldane or Van Slyke apparatus, or the Lexicon O2, and then the indirect is your fuel cell, like it's just a repeat essentially. But yeah, they're the ways in which you can measure oxygen, and I'll add that slide for you. Okay, carbon dioxide. All right, Pat, what is it?
Carbon dioxide, it is so CO2. So it's a carbon atom with 2 oxygen atoms joined. It is a gas. It is clear, colorless as well. It does not support combustion, and it is not flammable. And within the atmosphere, there's 0.004% oxygen at 1 atmosphere.
Okay, 0.00, yeah, CO2. Okay, cool. All right, so yeah, so it is, you're 100% right. So it is a polyatomic molecule, CO2. It is a metabolic byproduct of aerobic metabolism. It is produced where, Nikki?
So it's a part of anaerobic metabolism in the mitochondria.
Yeah, cool. So is it part of glycolysis, the citric acid cycle, or the electron transport chain?
Oh, I have not covered this yet, but it would be part of, I don't know.
All right, yeah, 33% chance of having a guess anyway. It's it's the Krebs cycle, or the citric acid cycle.
Yeah.
So for every acetyl CoA entering, you get 2 CO2 generated, and that's within the inner mitochondrial matrix, okay, as opposed to where the electron transport chain is. So we say that normally it's about 200 mils per minute in the 70 kilo adult male. If you do the math on that, it's 2.85 mils per kilogram per minute, I think. So, because we all know that oxygen is 3.5, we consume 3.5 mils per kilogram per minute as an adult versus 7 to 8 as a neonate. Then you can say, well, if my respiratory quotient is 0.8 for a Western diet, then my CO2 production is going to be, 2.85 mils per kilogram per minute in the adult.
Hey, Rudi, so isn't it also generated through the final step of the electron transport chain with complex?
No, I believe that's, are you talking about metabolic oxygen, metabolic water production?
I don't know, maybe I got this wrong, but I thought with the final step with the oxygen, it gets converted to, doesn't get converted to H2O and CO2.
No, CO2 is not, I'm fairly confident CO2 is not formed in the electron transport chain. I think it's the byproduct would be your ATP and your metabolic water, where you halve your oxygen and add a couple of hydrogen ions. And that's sort of, it's about, depending on text, about 50 to 100 mils per day. And then storage. So this is a good one. So does anyone want to talk to me about storage of CO2? Annika, perhaps?
Yeah, so it's like storage or carriage.
Yeah.
So
Either
carriage
or.
in the
Definitely.
blood, it's mostly bicarb, and then a small percentage carbamino compounds, and also dissolved.
Okay, all right. And do you know the rough percentages in the arterial blood?
I think it's like 95 and 5.
Yeah, correct. So 90 is your bicarb and then 5 are the others. And then we have our AV difference. Does anyone know the different, what the percentages change for the, now remember, this is AV difference. This isn't venous blood. This is the difference between the arterial and venous blood.
Yeah, so 60, 30 and 10 respectively.
Yeah, good. All right. And why does that occur? Why does this? Why do we all of a sudden have 30% being carried as carbamino compounds?
Because we've associated the oxygen from the hemoglobin, therefore our CO2 is now bound to.
Yeah, and what's that called?
Is that the Haldane effect?
Yeah. So our Haldane effect, there's a few components, but 70% of our Haldane effect is our carbamino compounds. The other 30% being the essentially the reduction or the HHB formation, which is a component of your Bohr effect, where you get your right shift in your P50 at the metabolic active tissues. And this is an SAQ that can go any way, including sort of the ventilatory response, and including drawing hamburger shift, chloride shift, whatever it is you want to call it, and then obviously your CO2 dissociation curves as well. Cool. All right, measurement. We'll skip it. Sorry, go on.
Sorry, this is a question that I'd had for a while. I don't know if you're able to answer it. What is the significance of AV difference? Like, why doesn't the textbook just write venous? Like, why doesn't it do arterial and venous? Why does it say AV difference? What is useful about that?
Because it's quantifying a percentage change based on deoxygenation. So it's essentially is showing you how well the allosteric change in hemoglobin based on a decreased oxygen carrying, a decreased saturation, therefore resulting in an increase in CO2 carrying capacity. And the importance of that clinically and physiologically is obviously carrying CO2, but buffering as well. Yeah. So when we talk about how the body deals with a respiratory or metabolic acidosis, and your answer is obviously going to be, well, there is buffering, compensation, and correction. And we talk about these pathways. Hemoglobin is obviously a very much an abundant system with 150 grams per liter. There's approximately 200 to 300 million hemoglobin molecules per red blood cell, and each one of those has 38 histidine residues on the imidazoles with a pK of 6.8, which changes. So that's sort of the relevance, and that's why we quantify the change. So this is a topic which basically covers several different parts of the syllabus: cardiovascular, neurology, renal, hepatic, measurement, everything, right? So it's really handy to just have a quick way to knock it out. So when we're talking about flow, okay, and in this context, I'm going to be talking about blood flow. All right, if I was to get a question about cerebral blood flow determinants, cardiovascular blood flow determinants, uterine blood flow determinants, these kinds of questions, I wanted to come up with something that was just an easy thing that I could always rely on to answer the question and not forget any factors, okay? Because you just don't want to miss easy points. So essentially, you're quickly going to talk about flow. You relate it to Ohm's law, obviously, all right? Or you can, for us, you can do Q is equal to delta P divided by resistance, whatever you want, or the actual electrical analogy there, not the hydraulic one. And then your determinants, basically assuming laminar flow, which we always do in our SAQs, unless I've specifically said something about turbulence, which we don't really talk about when it comes to the blood. You will talk about the Hagen-Poiseuille equation, and you'll knock it out really quickly. So they're basically the only two things you need to write fast, right? Are just your Ohm's law and then your Hagen-Poiseuille equation. If you're explaining this in a viva, I think it's important to say, to get out there, essentially that the resistance is inversely proportional to the fourth power, right? So that if you decrease your radius by half, you're going to get a 16 times increase in your resistance, which is significant. Now, the determinants of radius, the way that I sort of came up with this was so that I didn't forget anything. So you can see the first part is basically just part of the alphabet. So LMNOP, okay? All right, and then N diastolic volume. And if you can come up with something for the S, that'd be great, but I never could. So I just remembered S at the end of it. So the reason I haven't bolded all of these will become apparent soon, okay? So let's just talk through these. So you've gotten a question about cerebral blood flow, or what are the determinants of cerebral blood flow? What's normal cerebral blood flow, blah, 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 blah. So you quickly say, okay, cerebral blood flow, what is it? All right, it's the amount of, blood traversing the cerebral capillaries per unit time. And it's normally, 50 to 55 mils per 100 gram per minute, or 750 mils per minute, or 15% of cardiac output, whatever it is you want to say, right? I wouldn't be writing all of them down in the SAQ, just get one of them out, and that should be enough. The determinants, obviously there's some specific determinants when it comes to cerebral blood flow because it obeys the non-Kelly doctrine, but just in the interest of talking about radius and resistance, I've used this mnemonic. So, and this can be used for anything, okay? And I'll give you some examples. So L is just local, right? So local just means auto-regulation. So whenever we're talking, so if we're talking about the brain, this is now a map of 150 to 50 in the normal person. Obviously that's left shifted in the neonate and shortened and narrowed, and right shifted in the hypertensive patient. When we're talking about the heart, that's 60 to 100, or the left coronary artery, that's 60 to 180 millimeters of mercury. We're talking about the kidneys, it's 70 to 170. And if we're talking about the semi-reciprocal relationship with the liver, then it's a map less than 70, right? So they're just some quick auto-regulation ranges that you can now knock out depending on what SAQ you're getting, okay? So that's what local stood for. M was metabolic. So if we're talking about the brain, the three things we really care about, like straight off the bat, are going to be CO2, O2, and hydrogen ions, okay? And then the other thing is going to be temperature, okay? Then N is for neural. So obviously any innovation is going to change radius, okay? And they're just sort of quick ways, and you can use these no matter which organ system, which vascular bed you're talking about, you can always use this, all right? Now, O and P are only in there so that I didn't forget special populations, so obstetrics, specifically uterine blood flow with different pathologies such as, aortocaval compression, and pediatrics, okay, just for different auto-regulation ranges. So that's why I haven't bolded them, and it was just easy for me to remember LMNOP because I learned the alphabet. Never learned my times tables, but I learned the alphabet, so I can always remember LMNOP. And then end diastolic volume, so endocrine, all right, so this is all your catecholamines naturally occurring. D for drugs, V for viscosity, so that you don't forget the rheology component of your Hagen-Poiseuille equation, and then S is just for sick people, all right? So obviously if you've got sepsis, if you've got some kind of disorder of the vascular system, that's going to affect your resistance. And that was sort of just a quick way, like how I showed you with my SVT, great positive pressure ventilation, for me to quickly just nut out really quickly all the determinants of radius and therefore those things that would affect resistance.
Rudi, what was E and D again? Sorry.
So E is endocrine, D is drugs, V is viscosity, and S is for sick people. And then that way you kind of, you hit everything you need to when it comes to radius. And then obviously, if you're talking about cerebral blood flow, which we're not going through like specifically right now, you'd talk about the Monro-Kelly doctrine and, you know, central venous pressure and ICP, etc.
Rudi, as a utility for using this structure, which is really awesome, would you just kind of almost jot this down in your 15-minute pre-reading time? If you got like any sort of blood flow question, you could just jot that down, and then because you obviously you can choose what you'll do with based on what organ it is.
Yeah. So I was a bit of a dictator in study group. So anytime I had a study question, if they didn't like use a form that meant that they forgot something, then I made them repeat this 10 times. And essentially this way, whenever you get a flow question, you don't have to use this. I'm just saying have a structure, because on the day, we can do more of these sessions or one-on-one, whatever you want, as the day approaches, having something to quickly fall back on when you get an unexpected question is just, it's heaven sent, because time is not your friend. And you don't, you know, so thinking about, oh, how am I going to answer this is just really annoying. So having an automatic thought process to tackle these questions is good. And that's why I've come up with these mnemonics, which work for me. If they don't work for you, that's fine. Just come up with something that works for you. So yeah, I would basically go, you know, every time I got a question about flow, depending on the organ system, I would quickly go relative, so per 100 gram per minute. I would quickly go percent of cardiac output and total volume. I would then do the equation I needed, and not like ketamine nightmares, which is like an actual nightmare when you read some of the equations in that thing. You're never going to write them down in the SAQ, all right? So if you've not done the SAQ before, like, stop panicking. That shit just doesn't have it. You don't have time for it. It's a fantastic resource, but you cannot write it like that, and you don't need to write like that either to write a good answer. So you just need to quickly get out what the normal blood flow or what the normal range is, get out an easy equation, all right? And then you can go into the determinants, because that's normally what the question's about. You just need to answer the question, not give superfluous information that isn't actually answering the question. And so I would go, you know, local, metabolic, and I would write them out. I would space my pages, my 3 or 4 pages, and I would have a little bit of space for each one of those. And I knew what I was going to write. And then I would just quickly dot point, and then I would keep filling it out until I'd fill out enough. And I would move on at my 8.5 minutes or whatever it was. Any questions on flow?
Just a question generally. When you structured your answer like that in the exam, did you always write your answer chronologically, or did you dot your points and then go back and fill in the bits?
Why don't I just show you, like, I'll just show you at the end of this, I'll just put up a couple of examples of my practice SAQs, which look, you know, pretty much like my SAQs on the day. And you can sort of see, but like, I put a lot of effort into improving the way in which I wrote and structured, and Stan had a lot to do with that, so that it would be easy for the markers, essentially, because I am able to recall like a lot of specific detail, but my ability to write it so that people can actually read it was really bad. So I just spend like, you know, probably hundreds of hours perfecting just how to write the structure. So I'll show you sort of how I ended up writing things with a couple of images at the end, and you can sort of have a look. Any other questions about that?
Can I just check, sorry, so did you just go through for each of the organs and then flush out like what was the most important for each of the autoregulated organs, and then apply it?
Yeah, exactly. Like, you know, if you know, like the big one is going to be cerebral, you know, like, or coronary or whatever. Like, you always have to talk about, you know, if it's cerebral blood flow, obviously CO2 is, you know, like, you've done your autoregulation range, and then you're going to quickly talk about CO2, then you're going to talk about oxygen, and you're always going to talk about synergism, all right, because you get synergism. You're going to talk about hydrogen ions. You're going to talk about your Monro-Kelly doctrine. You're going to talk about temperature. So obviously cerebral metabolic rate and blood flow are really tightly regulated within the brain, because obviously it's a closed vault. And, you know, you decrease your CMRO2 by 7% per degree Celsius. So therefore you're going to get a linear reduction in cerebral blood flow. So like, those are things like I knew they were important things I wanted to get out quickly. And then, you know, neural's really not that important for the brain. So it was more like neural there's some SNS innervation to some of the pile arteries, and that's about it. You know, like you're not going to spend a whole lot of time on something that clearly isn't that important. It's more important for a question like that to talk about the things I've just mentioned, and also your Monro-Kelly doctrine.
So, Rudi, what was under sick patients? Like, what sort of examples?
Yeah, so sick patients essentially could be someone who, for instance, has, like I say, we'll just use this. So someone who's got a traumatic brain injury, or someone who's got meningoencephalitis. So you're going to have leaky capillaries, vasodilatation, increased blood flow pressure, blood flow, blood volume, and therefore ICP. So like you just quickly pick one salient sick like thing for that organ system or that capillary bed you're talking about. But that's like, you know, that's also like an extra marks kind of thing, I think. Like, I don't think that you have to put that in. That was just my way of trying to remember something for everything. All right. So I kind of already gave these to people. Okay, so when I'm talking about cerebral blood flow, so if I'm saying relative, then I just always pick 50 mils per 100 gram per minute, or 750 mil per minute, or 15% cardiac output, with an auto reg range of 50 to 150. That's your map, obviously. Does anyone have anything markedly different from that?
How do you sorry, Rudi, sometimes textbooks are comparing MAP and your cerebral perfusion pressure, which aren't exactly the same thing. So you just go with the MAP version?
Yeah, I think, look, I honestly, you can use your cerebral perfusion pressure. You can use your, I think MAP's probably the better one to do when you're talking about autoregulation. From my perspective, you can add other things like obviously the CMRO2. It's like 3 mils per gram per min, or 20% of baseline. These are all extra sort of numbers you can put down. You can add glucose too if you want to. That's all fine. Then for the heart, so your coronary blood flow. All right. So you can say it's about 80 mils, right? 80 mils per 100 gram min, or 250 mils total per minute, or how much percent of our cardiac output? About 5%, yeah? And the other thing, like, so if this was a question about coronary blood flow, and I think Nikki was asking about specific factors before, the other thing you're going to talk about here, right, is you're going to talk about the oxygen extraction ratio, because it's obviously an important factor and it's a differentiator, because it's going to be like 0.6 to 0.7 depending on the text, right? And then the other thing you're going to talk about is your Starling's resistor during your left ventricular contraction. And most of the good capillary beds have a Starling's resistor. Obviously, like the brain has one, the left coronary artery has one as well. And it just seems to be a good exam topic. All right, and then renal.
Rudi, I thought that the coronary blood flow was 250 mils a minute. In my mind, it was for both of them. I didn't realize it was just the like the left coronary artery that was 250. I thought it was like total.
No. It is total blood flow. Apologies, but I just wrote left coronary because we usually get this question about left ventricular blood flow.
Okay, yeah. But,
right. And regardless, it's still going to be 80 mils per 100 grams because it's a relative concept. So yeah, you are right. It's 250 total. And then renal blood flow. Okay, so what are we going to say? What's our relative blood flow? Someone want to tell me?
It's like I don't know the grams, but it's like 1,200 mils per minute.
Yeah. So that, yeah, you're right. So it's 1.2 liters per minute, and that's half for each kidney. All right. So essentially, it's an interesting one, but it's about 400 mils. All right, per 100 gram per minute. Okay. And that actually changes. So the outer cortex, the cortex it's 500, okay? The outer medulla, it's 100, and the inner medulla, it's 20, okay? With a total, as you said, of 12,000 mils per minute. Cool. And then percent of cardiac output, we all know, is about 25. Is anyone happy with that?
And then for your auto regulation, do you just have 70?
Oh yeah, sorry. 70 to 170.
Yeah.
But it's like there are differences. Like, you know, just pick something you're happy with. I'm happy with that. Some people will say 70 to 180 or 80 to 170 or 75. Like, ballpark. You know, don't get. You know, we're talking about very small percentage difference here, so don't get too stressed about it.
And do you include your oxygen extraction ratio as well? Sorry, do you exclude your oxygen extraction ratios as well for the?
Oh, well, it depends what the question is, right? Because like the overall, I mean, so here's the clinic. I mean, it's not a bad question. All right, let me explain. So overall, oxygen extraction ratio for the kidneys is, all right, 6.5%, all right? The clinical relevance, all right, of this oxygen extraction ratio, all right, is actually the differences, the regional variation, right? So the inner medulla, right, which gets, as we can see from here, the least amount of blood flow, agreed? So it gets decreased blood flow. The blood that gets there has a decreased PO2, all right? And what's in the inner medulla? What part of the nephron?
The collecting ducts as well are there.
Yeah, Lupin-Henle collecting ducts. So yeah, and the one we talk about is a thick ascending limb, right? And the reason we talk about this thick ascending limb is essentially that, you know, it's not showing. Yeah, so the thick ascending limb, and the reason we talk about the thick ascending limb is that it has an increased VO2, which is why essentially when you have a reduction in your blood flow to the kidneys, all right, this is sort of the area which is, you know, prone to ischemic insult and acute tubular necrosis, all right, because that's where you've got your chloride, 2 chloride potassium sodium pumps working their ass off to establish a medullary gradient, and you've got a decreased PO2 rocking up there, which clinically and physiologically, interestingly, is why the interstitium, sorry, it's really bad writing, stitchum, around about here is where EPO is secreted by, because those cells tend to drop in PO2 and then they secrete their EPO because they're good regulators of what the actual oxygen carrying capacity and therefore delivery is of the blood. Any questions on that?